Hello, everybody, and welcome to our webinar and fireside chat discussing the key findings around the 5th Australian Healthcare Index Report, a report created by the Australian Patients Association, an independent not-for-profit association dedicated to championing and protecting the rights and interests of patients, improving the patient experience and their health outcomes, and also commissioned by Healthengine, Australia's largest consumer healthcare online platform, helping millions of people every month navigate the complex world of healthcare and connecting them with the right care at the right place at the right time. My name is Dr. Marcus Tan. I'm the founder and CEO of Healthengine, and I'm your facilitator today. But I'm also joined by Stephen Mason, my counterpart, and the CEO of the Australian Patients Association, Bettina McMahon, who's the CEO of Healthdirect Australia, and Dr. Nick Coatsworth, a health reform leader, physician, and senior public administrator. Thank you for joining everybody on the panel. We're also joined online by a bunch of people who are part of the greater healthcare ecosystem and those who also just love healthcare, and we're very pleased to have you all. We're actually very keen to hear from those people who are online, and so please put any questions that you have in the Q&A section, and we'll try and get as many questions answered as we can by the panel in the hour that we have. To sort of talk a little bit about the healthcare index, more than 10,000 Australians were actually interviewed or participated in the survey that contributed to the Australian Healthcare Index report. And if you haven't already downloaded the report, please visit australianhealthcareindex.com.au and you can get access to an interactive dashboard for more specific state and demographic insights as well. So check that out. And just as a quick overview for those who haven't exactly seen some of the results, the first thing that we tend to do is ask patients whether they're about their satisfaction with their healthcare index. And over the last 2.5 years since we started the index and pulse checking every 6 months, we've actually seen a very gradual decline every time we've surveyed of patient satisfaction and experience of healthcare in Australia. It currently started at 7.8 and it's now at 7. And the way it's going, it's going to drop below 7 the next time we pulse check this, which is a pretty concerning sort of trend that we're seeing. The top 3 concerns that we're seeing this time around, which reflects what we see last time around, but probably worse. Firstly is GP out-of-pocket costs and those concerns around affordability, the GP nurse and healthcare workforce shortage, and obviously the ability to see people in a timely fashion, and probably related somewhat to that are emergency department wait times. So as I said, this hasn't really changed in terms of the 3 concerns that most people have from the ones that were surveyed in the November report. But it's something like GP out-of-pocket cost as an example. The concern around that went from 33% to 43%. So it's pretty interesting trends there. I guess the other thing to note is that since we've spoken, there continues to be a clear theme that consumers and patients are concerned about their healthcare costs in general and access to care. But the federal government has obviously in the recent budget announcements included $101 billion for healthcare spend, with $5.7 billion earmarked for a building of a stronger Medicare system. And we'll talk a little bit about that later on today. So look, always starting with the patient in mind, I always like to start with Stephen. Stephen, obviously, having heard that these results and seen these results from the survey, any sort of concerns that you might add from the patient's perspective, and does that kind of resonate with some of the stories that you're hearing in the market at the moment?
Marcus, it does. Patients are concerned about cost of living pressures. They can't afford an $80 fee to see a doctor, so too many of them are now either deferring appointments to see a GP or going less often. A big concern for a lot of younger people, particularly in the 18 to 35 cohort, is the disappearance of bulk billing. These people on low incomes that are struggling with rent and transport costs just can't afford an $80 out of pocket. So they're looking for bulk billing clinics, but they're hard to find nowadays. In addition to that, there's still a lot of concern about cost of prescriptions. There's still quite a few people on low incomes that are struggling to afford all of their prescription medications. So that is an issue that isn't going away.
Yeah, so that's pretty concerning. Now, just over to you, Bettina, and Healthdirect Australia, for some of those people on the call who may not be entirely familiar with it, can you give me the two-second elevator pitch on Healthdirect Australia? Who funds it? What do you guys do?
Thanks, Marcus. Good morning, everyone. So Healthdirect Australia is funded by all Australian governments. We provide 24/7 phone lines and digital services to Australians to get health information, advice, triage and navigation assistance. So last year we had about 120 million interactions with Australians. Just under 10 million of those were phone. So digital is a massive channel for us.
Yeah, and we're actually really happy to be at Healthengine, a partner of Healthdirect Australia. So it's great working with you. Look, I guess one of the things around one of the big things obviously about getting health information is also the governments are very keen to obviously have people go to the right services at the right time, and certainly emergency departments being full. There has been talk and a lot of investment in things like urgent care clinics and so on. And in fact, one of the initiatives that we're working with Healthdirect actually is around finding urgent care clinics and so on as one of the things to try and help people divert from going to ED inappropriately potentially. What do you can you talk about where the place of urgent care, where you're seeing it? Are people actually understanding what urgent care is, and how would they find out about it?
Yeah, look, good point. The point that Stephen made earlier about certain cohorts of consumers avoiding primary care because of the cost, we're also seeing the availability of primary care being a real challenge. And quite often people will then go to emergency departments as a backstop because they know they're open, they know they can go there and get a service eventually, and they know it doesn't cost them anything. So that has been a natural pathway for consumers when they struggle to access good primary care. So there's a few things that governments and we're working on. One of them is urgent care services. So this is where people with episodic care needs can go somewhere that's not an emergency department where it needs face-to-face. The other thing we're doing, though, a lot more with governments is virtual care. So of the cohort of people who could be dealt with in primary care but otherwise might go to ED because they can't get into a GP, around between 40 and 50% of them could be suitable for telehealth. So obviously some people need a physical examination, but quite a few of them can have a virtual consult. So for us, it's actually understanding all of those pathways. It's the virtual care pathways. With urgent care services, we're trying to be really specific about what's the scope of practice in each urgent care centre, because not all of them offer the same services. So we need to be really specific about, well, what do they offer? What are their hours of operation? And what's their availability? So we're working with Healthengine and the other the 12 major booking engines, basically, so that we can see real-time availability of bookings, so that when we're talking to a consumer, particularly on the phone line, we can say to them, look, you need to see a GP really within the next 2 hours. And there's an urgent care service over here and they've got some availability for bookings. And this coming financial year, we'll be able to even make the booking for them and push through information of the triage through to the urgent care service to improve continuity of care.
That's great. And maybe just changing gears a little bit, just over to you, Nick. And Nick, you've joined as the brand ambassador for health reform with the Australian Patient Association, but obviously a lot of people would recognise you. You've been very prominent, particularly over COVID, in quite a few government campaigns, particularly. So I think you understand how government thinks in many ways. And obviously, with the recent budget announcements, do you think the plans for bulk billing are going to make any impact at all on some of the GP cost concerns?
Yeah, look, Marcus, the first thing I might just respond to Bettina's comments and say that, the progress that Healthdirect's making there, really, really exciting opportunities there to streamline booking systems and access entry points. So that's really good to hear. From the perspective of the bulk billing incentive, of course, there was a tripling of the bulk billing incentive. So what happens? Many online will be aware, but just to explain it, and I'm not a GP, so Marcus is going to jump in if I get any of this wrong, but you've got your base level consultation fee, and if you bulk bill for that, you get an extra amount of money. So the patient pays nothing, but the clinician actually gets an incentive payment for that bulk billing. Now, even the incentive payment was rather small, I think in the order of Marcus, how much was the bulk billing incentive? Was it about 10 or 11 bucks or something like that?
About that, yeah.
And I mean, we can intuitively sense that that's not enough. And I see Chris Denz has asked a question in the Q&A about the out-of-pocket costs and of seeing a GP. We can intuitively say that 11 bucks is not going to shift the dial for a general practitioner who then has to pay all the on costs to the practice. And what we also need to realise about GP out-of-pocket costs, and the same for me as a physician, when you see someone privately, it's not just that 15 minutes. I'd estimate at least a 1-to-1 ratio of the time you spend with a patient to the time you have to spend after following it up. But for some patients, it's significantly more than that. So this is what's driving these cost pressures. Tripling of the bulk billing incentive is going to shift the dial, but we don't necessarily know how much. What was really exciting, I think, was that there was a recognition that the incentive scheme needed to be changed for very rural and remote general practices, where their incentive for bulk billing is now significantly higher. So a general practitioner will get about $67 to do a standard 15-minute consultation under the new scheme. Now, that sounds to me like it should change the rate of bulk billing quite significantly, but ultimately, we need to see what happens on the 1st of November when this comes in. I am a little concerned that there's no, it's very hard to mandate a rate of bulk billing, but government has sort of said, here's the money, and then left it between the GP and the patient to sort of work out. So there could be some quite uncomfortable conversations there come November 1, when a significant number of Australians expect to be bulk billed, and maybe some of them don't get to be bulk billed. So I think I'm interested with some degree of trepidation, but with some degree of hope, to see what's going to happen in the 1st of November.
Yeah, thanks for the setup, Nick. I think we can talk a little bit about bulk billing and who it applies to, and why it may actually create gaps or cracks in the system for certain cohorts of people. But we'll talk about that later. So let's talk a little bit about primary care. We have sort of alluded to it. There are some trials, obviously, or challenges in primary care, but there appears to be a bit of a issue where the trials of pharmacists prescribing underway in Queensland and New South Wales, where pharmacy and GP communities with opposing views on how this actually values the patient. Yet in the Australian Healthcare Index survey, we see the majority of people are actually interested in the ability for pharmacists to actually prescribe. And maybe that's from a convenience standpoint, and they already see a pharmacist as a go-to for healthcare advice. I guess sometimes the problem is that convenience in healthcare can seem like a bit of a pejorative term in some ways, because it's almost seen as a compromise to quality. But does it actually have to be mutually exclusive? Bettina, do you have any thoughts on, we talked a little about telehealth tools as an example. Convenience in this situation, can sometimes be seen as not necessarily as good. And you kind of almost alluded to that just previously. And for some of those who aren't aware, Bettina used to be the CEO of the Australian Digital Health Agency. So, there was, you understand telehealth well. What do you make of the crackdown by the medical board on forms-based prescriptions and consultations where the patient's never been seen by the doctor before? Do you feel that that's simply a conservative sort of bureaucrat sort of impeding innovation and shutting down the potential for viable other different models of care? Or is this actually genuinely a safety problem?
Look, I think in the longer term, virtual care is going to play a much more prominent role, partly around convenience, but also environmental considerations and utilisation of capacity. So I think it's here to stay. The big question, though, what you're talking about is what's safe now and what might be safe into the future. So I'm really comfortable with the way that so the pharmacy trials, for example, have been conducted. I mean, it was 10 years ago, Queensland started trialling UTI treatment in pharmacy rather than general practice referral through, and contraceptive pill, I think, repeats. So there's a trial in New South Wales at the moment too. So they're quite thoughtfully created trials that are evaluated. And then from that, Healthdirect, for example, will capture the expanded scope of practice in pharmacy, and we can then tip people into those or point them to those services if they have a suspected UTI, for example. I think the area that's less well evaluated has been asynchronous prescriptions and and Healthdirect actually made a submission into the medical board's review process where we didn't see a lot of evidence to date around the safety of asynchronous prescriptions. That said, we didn't think they should be ruled out entirely. So I think there's a gap on how this can be evaluated, and I'd love to see some more work on that. That said, we're quite comfortable with the updated guidelines that have been put out. We were a little concerned that they might go a little too far and say you can't provide prescriptions in virtual care, which we think would be nonsensical. We think it can be very safe and it works very well in some circumstances. There are certain things that we don't do in our GP online services, so we don't prescribe drugs of dependence. So there's a certain number of class of things that aren't suitable for episodic telehealth consultations. But I think where we'll end up in 5 years' time will be in a much broader scope of virtual care practice than we are now. But I think it's very important that there's thoughtful trials and evaluations done to give everybody confidence that it's safe as well as being convenient.
Yeah, no, I think that's that makes sense. And I'm just going to actually touch on we have a question, and thank you please to all those people who are actually putting questions into the Q&A. Please feel free to continue doing that. We do have a question from a consumer from Denise, who's a consumer from regional East Gippsland, and she was talking about the concerns about regional residents and the equality of access. Costs and travels being a particular big issue, and going digital. So I think we've kind of talked a little bit about that. But she did make a point around seeing the My Health record as something that, unfortunately, clinicians, surgeons, and other parts of the healthcare system aren't necessarily updating into the My Health record. And given that your background in the Australian Digital Health Agency, I don't know whether you've got any sort of particular comments around how you can get a more complete data set for patients and consumers.
Yeah, look, I'm a big fan of the My Health record, unsurprisingly. Was involved in its implementation for over a decade. I think as far as we can, as much as possible, we should be looking at automated uploads with an opt-out mechanism. So pathology tests, for example, it's no additional work for a pathologist or a person kind of to do this individually. It's just the system integration and agreement from that company to do it. We've already got that with prescriptions, so they automatically go up. So I think the more that we can look at how systems can actually upload this information, that's kind of the fastest track to adoption. There is always going to be a role, I think, for clinical judgment to say, actually, I think this needs to go in, and some pushing in there. But that's, I don't think the focus should be on that. The focus should be on how can we actually get more content in here. And then there's the other point you raised, Marcus, about, well, then what's the onus then on healthcare providers to be considering those notes as part of their treatment? And there's a way to go. I mean, the excuses to date have been, well, there's not enough content in there, but it's kind of chicken and egg as well. So there is an obligation on the agency, and I think they're doing quite well to get data in there. But there is a point where the value of that data needs to start being considered, particularly when people are transitioning across care settings. So a bit of an onus back on clinicians, I think, too, to start to say, okay, maybe we need to start doing this a bit more thoroughly.
Yeah, no, that's a good point. Nick, just going back to you, I mean, as a healthcare reformer, and obviously you're on the medical side in many ways, but probably more on the patient side in some ways, in the same way that I am. Like, how do you bridge the turf war between groups like the pharmacists and the GPs, who all have reasons to actually sort of want to increase their scope of practice, but to sort of put patients first and address the safety and quality concerns that are being raised, but tempered with the benefits of access? Like, how do you see that we can actually make this happen so that everybody can play nicely in the sandpit?
Yeah. So one thing I would say to everyone online is that, when you read this sort of stuff about turf wars in the media, no doubt there's a core of truth to it. But it's not as though GPs and pharmacists are at 10 paces in your local shopping mall staring each other down. That's not what's happening at all. And in fact, what is actually happening is that there's a majority of frontline practitioners across all clinical specialties and professions actually doing their best to work together. I think that the peak bodies themselves, and we had them all together at a regional health conference in Mildura a couple of months ago, and I challenged them with the same question. What is the point? What is the point of the pharmacy on Guild on one hand sort of suggesting that the GP leadership, I think the word was used, twits, and what is the role on the other hand of the president of the College of General Practitioners writing on their personal Facebook page that it's great that the Guild have been undermined in the recent budget. Now, neither of those things are necessary. So I think there's a little bit of true leadership would not involve either of those sort of comments, even though both comments were made in private to a sort of friendly audience. And it allows the media to fan this sort of so-called turf war. But so then the last thing that I'd say, because I'd really like to hear from other panelists on this, it's a really contentious issue. But if you go back to basic principles, and there are sort of universal healthcare principles that the WHO put out, the Australian Patients Association has a similar set of patient principles. But if you talk about, okay, we want equity in access, at the moment, you can't achieve equity of access with the traditional and quite antiquated model of face-to-face primary care with a general practitioner. You can't do it. We don't have the resources. So then you have to look at the other options, do it in a safe way, and then evaluate it. Now, one of the difficulties is there's so many different possibilities with telehealth that the pace of evaluation may not keep up with the pace of innovation. And that's sort of what's happened with this so-called asynchronous prescribing, where you fill out a form and get a result. But at the same time, you could argue that the digitally enabled systems are the most likely to be able to be evaluated because the data's there. So 2 points. Avoid the turf wars through sticking to the principles rather than the professions, and making sure that the new innovations are quickly evaluated.
Yeah. So and Nick, you bring up some good points, and I'm going to throw it over to Stephen because Nick, talking about principles, I mean, two of the key principles in healthcare that I think everybody roundly believes in as being helpful, particularly in primary care, is this idea of continuity of care, and also the idea of not having sort of conflicts associated with perverse incentives to do things that maybe might be good for the hip pocket of certain people, but not necessarily good for the health outcomes of others, right? So I think when and it's kind of alluded in some of the questions in the Q&A as well around the separation of prescribing and diagnosing dispensing, that split between pharmacists and GP has always kind of been a little bit sacrosanct, and now that's kind of been a little bit collapsed in, and that's one of those principles that have been challenged. And I suppose the other thing, and it's again alluded to by one of the questions, is this issue of continuity of care and sort of cherry picking sometimes things that are easy and convenient, but not necessarily broad and holistic. That's that's something that GPs hold very, very dear to their hearts, and it's really important that and we just talked about my health record as well, and using that as a way of ensuring that everybody has the same picture or snapshot of the patient. Stephen, I guess throwing back to you, I mean, how do you reconcile this importance for convenience and access over quality and safety?
Patients like convenience and easy access. They do like telehealth appointments, and there's quite a few firms in this space now, Instance Groups, MedMate, Eucalyptus, etc. But they're getting millions of appointments each year, millions. So it's really grown over the last 3 years since COVID. There's a lot of people out there with mobility issues. Others live in rural, remote areas. Others have instant crisis. Nick was in the office a month ago, and one of the people we were talking to had an asthma attack and urgently needed a new puffer, and he was able to get a prescription to go over to the pharmacist over the road. So it comes in handy in a lot of instances. Nick and I have spoken to a lot of these telehealth providers, and they've assured us they use registered doctors. They refer to the medical notes for the patient, but they agree there's got to be boundaries around it. So it did need some tightening up. It did need some boundaries, but I agree with Bettina, virtual health's the way of the future. So we've got to go that way, and the rules have to change. Right. And one final thing that came through talking to these telehealth providers is that they've got a reputation at stake. If they do the wrong thing, they'll kill their business. So it's in their interest to provide good, safe advice and not stray outside the boundaries. So to date, we've had very few complaints about telehealth appointments. So I don't think it is a big issue of patients getting poor advice and suffering as a result.
Thanks, Stephen. I might just change gears a bit and just go back to the conversation we were having about certain cohorts that are particularly disadvantaged in the current sort of cost pressure environment. We did allude to the fact that that there's a particular group in the 18 and 34-year-old age group, the sort of digital natives, Gen Z, millennial sort of age groups that seem to be significantly overrepresented in some of the challenges here. Like, as an example, they're an age group in the survey that seems to be skipping care more often, either dental or GP due to cost. They also seem to have, more access. The stat seems to be that 1 in 3 people in that cohort and that age cohort have actually sought mental health services in the last 6 months, compared to say 1 in 4 for the rest of the population. So they seem to be accessing mental health care more readily, and maybe that's because they care more about mental health, or they have more mental health challenges. It's a little hard to know, but that's certainly seemingly an interesting stat. And lastly, they're also not accessing certain types of diagnostic tests and delaying the filling of prescriptions and that sort of thing. So some pretty alarming sort of stuff that, if I, as a GP, I'd be pretty concerned if I was hearing that happening with some of my patients around compliance and other things. I guess, Bettina, this specific cohort is actually also increasingly turning to Dr. Google, right? Because it's free, it's easy to access, and instead of seeing a GP, this is the thing that's at your fingertips. I guess using online resources and seeing GPs, is that a good thing? Healthdirect, obviously, like Healthengine, we're both online consumer resources that's supposed to help consumers navigate this complex healthcare system. But do you have concerns about this behavioural trend?
Not at all. And in fact, I've got more concerns about some in the health community who sort of throw their hands up about Dr. Google. I'm sure everyone on this call, if you had a health question, would you really book a GP appointment before you went online, just curiously to search it? It's happening. And so I think, for Healthdirect, we accept that. The part we don't accept is people looking at poor quality health advice and information. So what we try to do is we've got our own knowledge base, which is clinically curated. We have information partners who are trusted. And so what our objective is to make sure that when consumers in Australia search for health, they have health questions, that they get quality information and advice. We think it's a natural part of what they're doing. We think it should be supported. As I mentioned, 120 million interactions we had last year, less than 10 were on the phone. And a lot of that, a lot of it was for bookings, but a lot of it was also just health information. So I think it's for us to accept that this is a legitimate activity consumers do. It's a cost-effective one as well. And so long as they can get access to good advice, it can be the first step in a care pathway. And we are seeing, you mentioned the 18 to 34 cohort, there's different preferences as well. I mean, one feature, for example, is men in their 20s are much more likely to seek online information about mental health issues before they want to speak to someone, even in a telehealth consultation. So as a pathway into starting to consider their own mental health and whether they need to seek care and then how to do that, that is a really legitimate step that they're taking, and we welcome that.
Yeah, great. And I guess on the same theme, Nick, I mean, you're, as I mentioned earlier, you're obviously involved in a lot of the sort of public health campaigns, educating the public about some of the various health initiatives addressing COVID a couple of years ago. What's your take on health literacy and better educating consumers about accessing good health advice, the importance of medication compliance, the appropriate use of services, those sorts of things? Like, how do you think we can do better around that?
Look, Marcus, you mentioned my COVID experience. I mean, I guess I I guess consumers had and Australians had a long time to sort of sit and Google stuff then, but I think we underestimate the health literacy of our population. I think that, yes, it's something that we always have to raise, and yes, there's specific groups within the community for whom health literacy is naturally more difficult, but particularly those from culturally and linguistically diverse backgrounds for whom the information simply isn't presented in necessarily in an accessible format. But the COVID experience was that people were hungry for information. They absorbed that information, and when I was doing the webinars like this, the detail of the question that people were able to present, particularly with regard to the vaccines, was well, it surprised me. So I think the subtext to your question is, though, how is a consumer supposed to differentiate between a quality and a not quality service? I would say that that's a problem for face-to-face interactions anyway. You don't actually know if your doctor's a good doctor until they stuff up or fix you, I suppose. But maybe it's particularly concerning online. But if that is a concern, then I think the answer is for those online providers. A lot of them have been worried but embraced the new guidelines for telehealth. They've committed to better quality and safety evaluation. And then it would be up to government through organisations like Healthdirect and their other communication channels to say, look, these are the sort of pathways we endorse, and there's a multiplicity of them.
And just going back to you, Stephen, I mean, this cohort of 18 to 34, we talked about the bulk billing incentive, and really that only applies to the seniors, concession card holders and kids. So this group often are the ones that kind of definitely don't qualify for the bulk billing incentives that everybody's looking for. And recognizing that bulk billing is really, when we talk about that, no out-of-pocket cost, but subsidized by government, and it's actually the patient rebate, not the doctor's payment. And this is an area where I guess if you are considering this group is starting to look like they're falling through the cracks of the health system, what else can we do to help this particular group?
Well, you are correct, Marcus. In this cohort, 18 to 35, they're generally in insecure jobs, casual work, and that's a problem for them. As we heard, 1 in 3 are suffering from mental health issues, and our patron Zena Burgess, who's a psychologist and CEO of the APS, said we probably understate that figure. There's a lot of people who don't admit to having mental health issues. She thinks it could be closer to 1 in 2. So it's very concerning. But these people are struggling financially due to cost of living pressures. They need to go to a bulk billing clinic. We don't want them to neglect their health. We know they can't afford an $80 out of pocket to visit a doctor. Then there's prescription costs as well. So we've got to do something about providing more bulk billing opportunities for those on low incomes. Maybe we've got to look at some sort of means test. If your income's below 50,000, there's got to be a category for this cohort so they're not forgotten. Because if they are forgotten, their health will deteriorate, and the whole Australian population will pay a price for it.
And I think that's a good segue to our next topic, which is talking more broadly about Medicare and the system. Australia's been, a system that is known to be one of the best health systems in the world, and I think a good part of that is this idea of universal healthcare. At least the ability for patients to be able to access healthcare irrespective of their socioeconomic status, which again, I think we've got some concerns that may well be being eroded. In fact, 6 months ago, we actually had Stephen Duckett, who many of you will know is a fairly prominent health economist, who was on the Strengthening Medicare Task Force. He was on this webinar, and he was unable to say about the results of their work because they hadn't quite released the recommendations yet. But now we are seeing some of the outputs of that task force. Just maybe for the group, I mean, how do we feel about the Strengthening Medicare Task Force program, the quantum of investment that that is being made? Is it going to the right areas or to the right patients? And there was one particular area around voluntary patient enrolment. Nick, maybe you might want to comment about that. But more broadly, like how do we feel about this program? Is it going to do what it's supposed to do?
I mean, I think the unanswered question there, Marcus, is nobody's actually decided what it is it's supposed to do. And by which I mean, Minister Butler was asked this question, and it could have been Minister Hunt or any health minister in the past 20 years. But he was asked a question at a press conference about 6 months ago. Does Australia, actually it was at the conference where he released the Medicare Task Force report, does Australia actually have a universal healthcare system? And his response to that was yes, because anyone with an emergency can go and get free healthcare and be admitted to hospital. Now, if that's our definition of a universal healthcare system, I think that's likely to be wildly different between Minister Butler and the rest of the country, maybe. But regardless of what the definition is, we can't create a system unless we know what we want to achieve. So do we, and I saw, thank you to Chris Dens for his ongoing contributions in the Q&A, but Chris's first question was, what's the problem with paying for a GP when it's the same as filling up a tank of fuel? Well, good question. Previous health ministers, I think it was potentially Minister Abbott when he was health minister, floated the idea of a $5 co-payment. Now, a $5 co-payment looks like peanuts when it's now got an extra zero on the end and we're paying $50. So I think I don't think we're going to get back to a system where primary care is free for the majority of Australians. We're a couple of decades past that. So then the question is, what is a reasonable amount for Australians to pay for primary care? That is to see a general practitioner or another primary caregiver. And can we look at the people who are falling through the gaps with enough granularity to do as what Stephen suggested and bring in other ways beyond just a sort of big bulk billing incentive to really target those patients? And I've probably said enough with this answer. We can get onto the different funding mechanisms apart from fee-for-service, which is one of the ways you can achieve that.
I'll add something else. So Stephen Duckett's on the Healthdirect board now. He's one of our independent directors, and so he brings some of this thinking into our planning. What I'd say about the voluntary registration, I'll comment just on that part, is it supports our idea that that there's no one solution. There's no, for a guy in their 20s, there may not be value in having the same GP practice they go to, all the time. But there might be for a parent with young children who have some complications. So it's kind of horses for courses. And I think the report reflects that, in that it doesn't say this is for everybody in the way that it is in the NHS, as I understand, with the registration there. But it's trying to identify, well, who would benefit most from having a regular GP for continuity of care. And some of the work we did during COVID with a few states, New South Wales, Queensland, South Australia, was they helped identify patients who had COVID and were at higher risk of severe disease. They passed through the data on those patients with their regular GP, because there were surveys that kind of got this from the consumers with their consent. And we then connected them with their regular GP with information that they might be eligible for antivirals, assisted with the booking. So it meant that for that cohort, there's a specific cohort where there was an immediate benefit for them to get a fast track access to their GP for the purpose of an e-prescription. And we found that about 30% of that cohort didn't nominate a regular GP. And these are people who had either underlying chronic conditions or who were older. So to be eligible for the antivirals, you had to kind of be in that cohort. So I guess that was a surprise to us. And I think that's what the Strengthening Medicare Task Force report looked at, is there's probably a whole bunch of Australians out there who don't have a regular GP and who would benefit from that personally. And the health system would benefit from the management of their care in a more coordinated way. So I think that makes sense to me. But that's just about that cohort. So I think there's a lot of other problems to solve that the report didn't try to solve, and I can't do everything at once. But I think for that part it made sense to us.
Any question? Any comments, Stephen, on that?
No.
No, it's fine. I mean, one of the other things that Stephen Duckett, did mention when he was on the last webinar was that he felt that it was important to have, or at least advocate for, a universal dental program. We know that in this survey, we actually asked people if they'd actually be willing to pay a higher Medicare levy to have dental cover covered dental care covered by Medicare, and more than half actually said yes. So there's certainly an interest that maybe the private health insurance sector, who obviously are historically the people who've covered dental care, may not be covering enough, or doesn't provide the sufficient coverage in order to provide access. What are our views about dentists and having a regular dentist, and cost concerns around minimising people not accessing dental care?
Well, Marcus, dental concerns have been a key issue of the survey for some time. We know that less than 50% of those respondents have a regular dentist. They don't like the experience, and they don't like the cost, and it's very expensive going to a dentist. But poor oral care leads to poor health. We've got to do something about it. We know that when Medibank Medicare was originally set up 50 years ago, the government couldn't get the support of the dentist to be part of Medibank, as it was then called. So we've recently made a submission on dental care, and in our strengthening Medicare submissions, we say that dental care should be included. But we know it'll take time, and as Stephen Duckett has pointed out, it's going to cost a fortune. It is pleasing to see that most of the respondents would accept the increase in the Medicare levy to cover that, but would only partly cover the costs. But we do need something to do. We do need to address this. It's going to be a long-term issue, but really, at first, we need to look after the needy, those on low incomes. I think it's a bit like having a GP's appointment. We can't afford to give free care for everyone. It really just needs to be directed to those in most need. The rest have to pay for their own dental treatment.
I mean, Stephen raises some interesting points there, and one of them is that dental care is almost the inverse of medical care in terms of when you want it and need it in your life. You want your dental care to be formed as a habit as a child and an adolescent, and nearly all of the consequences of poor dentition occur to you in adulthood and then later in life. As an infectious disease physician, I see people with infections on their heart valve, endocarditis, because they've got poor dentition. So two things about dental care. I think if it's going to be free, you could seriously argue, and I think we did, Stephen, in our submission, that it only be free for up until you finish adolescence when you're 18, or maybe you want to peg the number at 25 or wherever, because it may not be affordable to give. And the second thing is, don't make the same mistake, or I won't say mistakes. It's not a mistake. It's been a great policy for Australia, but learn from the current challenges of Medicare, and don't form a Denticare that mirrors what Medicare looks like now.
Nick, that's true. It's just for younger people. When you're going to school, you need to get into the habit of regularly visiting a dentist, checking on the health of your teeth, and hopefully that develops good habits to continue later on in life. So once you start earning an income, you can afford to see a dentist.
That's great, and I guess we're actually coming almost to time, and I just want to make sure that anybody who's got questions are able to have those questions answered. So please do feel free to put some stuff in there. Just on the subject of dental treatment, Denise, who's actually made a comment in there about untreated dental health can lead to unwanted general health and even emergency care, and she says that dental health care should be part of any health plan, service, and insurance. I think that's actually quite well recognised that there is an association between dental care, dental health, and just general overall health. And I think that's the connection there is quite strong. I think the point here is that if you look into the future, it looks like, just based on what we're talking about, that governments are going to struggle to continue to finance healthcare in the way that that they might have historically. The notion that we have some sort of a social compact in Australia that healthcare is free maybe needs to be disavowed, just given the fact that economically it doesn't make sense. I think Chris Dens, who is a GP, and also made a point that, the indexation on Medicare was 1.6%, whereas everybody can see general inflation being significantly more than that, certainly over the last couple of years. So, is this going to be just a situation where basically we have the haves and the have-nots? Those who can afford will have choice and they'll have the best of possible care, and those that can't will go to government-funded clinics and not have a lot of choice, but that's just going to be their lot. Is that what universal healthcare will look like in the future?
I suspect so. It'll be a bit like hospital treatment. If you can't afford private health insurance and select your own private hospital and your own surgeon, you go to a public hospital, and I think that's the way it'll end up.
Yeah, I mean, I do wonder if there's a very big structural problem with going in that direction that needs to be addressed, and it was a big finding in the healthcare index, which is, if you've got a state system that provides things for free and another system that doesn't, then you're going to overwhelm the free system. So I don't think we can sort of disavow it. We've just got to sort of make sure the balance is there so that people who would otherwise access state-funded health departments can access primary care in an affordable way. The other thing is on the cost issue, just very quickly, I saw Chris may not like this comment. It's coming anyway, but I'll balance it with a comment about the pharmacists as well. When government tries to reform, like they've done with 60-day prescribing, there may well be some problems with 60-day prescribing, but ultimately, one of the reasons that they're doing it is to save the healthcare dollar. Equally, I don't think there should be a rebate to report an ECG. I think that the machine reports it for you. There's absolutely no need for a cardiologist or a general practitioner or anyone to get an ECG rebate in this day and age. So we have to accept in our professions, getting back to the turf war, that we're going to have to give a little bit and say, okay, well, I accept that saving is going to be an impost on my income, but it's a saving for the health system.
That's great. And look, I guess just addressing another one of the questions, and this is kind of a question from Trudy, just around the prescription medication findings of the index, and mostly directed to Nick, but what changes would you like to see to address this? I wasn't 100% sure, Trudy, what you were actually referring to, but just to give you a sense from the index itself, the index suggested that about 66% of people who were surveyed were currently taking prescription medications, and 58% said that prescription medications is affordable to meet, suggesting that the other 42% suggested that they might not be affordable. Let me see. It says, have you had to go without prescription medications due to cost concerns in the past 6 months? And 27% said yes. Now, there appears to have been a drop in the co-payment associated with the PBS as part of that question as well, and there was asking whether that made prescription medication more affordable. And a third of people said yes, it was more affordable. I guess there's been a lot of talk about prescription medications, particularly around the ability to get 2 months worth of 60-day prescribing side of things in the media as well. And again, you talk about turf wars, and you talk about so impacts to people's businesses and so on. I'm not sure, Trudy, whether that's what you're kind of alluding to, but most people, I think, agree that a lot of these decisions have been made and are actually pretty beneficial to patients. But I'm not sure whether either part of the health sector actually in pharmacy or GP necessarily always agree on some of these sorts of policy decisions. Where do you think it goes, Nick? Do you think that this is going to be an ongoing issue around prescription medication?
Yeah, I mean, I'd probably just very quickly and then over to my colleagues for a response, but focus on the affordability side of prescription medicines. It does result in unplanned admissions to hospital. There are patients. I had one the other day, a young person on multiple cardiac medications who was paying up to $150 a month for the totality of their medications, and so 60-day prescribing will make a difference. The point at which your cap kicks in, your sort of Medicare cost cap, I can't remember what it's called, but that probably needs to come down a little bit to facilitate all those people who are on multiple different medications who don't necessarily have concession cards. not skipping their meds. So in contrast to sort of the different ways that we access primary care, I think once a drug's prescribed, you got to be able to make it affordable for the patient and as affordable as possible.
I concur with Nick's comments, but it is interesting to note that the New Zealand government recently scrapped the co-payment. So there's no co-payment in New Zealand. And I am told by a few pharmacists, even with the reduced co-payment of $30, by international standards, that's still on the high side.
The only other thing I'd add actually is a bit of a plug for My Health Record again. So when I was at the agency, the University of Wollongong partnered with us and did a study on when a medication review was undertaken by a GP and informed by the My Health Record. So, that work showed the role the My Health Record could have in a GP understanding the full range of prescription medicines a person was on, which wasn't always aligned. Actually, it was mostly not aligned with what was in their own clinical information system. Anyway, there was a couple of hundred patients who had meds reviews, and quite a lot of them had, I can't remember the exact figures, but actually had some de-prescribing as part of that process, which had some benefits of improving patient safety around the reduced contraindication risk or symptoms, and of course a financial one to both the government and the patients. So it wasn't massive changes, but I think the point is there's also a role for using information systems and information sharing to improve the quality of meds reviews, maybe more frequently, to ensure that the medication program somebody's on is suitable to their current condition, and that could reduce cost of unnecessary prescribing.
Thanks, Bettina. I've got a question here from Karen for Nick, but I'm actually going to repurpose this question a little bit, but I'll get Nick to answer the question first so that everybody can answer. But from the patient lens, what would you measure as the top 3 for a successful health reform?
Thanks, Karen. Karen's a friend and colleague from Victoria. Look, number 1 would be heavy investment in preventive health. Number 2 would be access, and number 3 would be affordability. But the problem is that they're sort of, their motherhood statements. What that actually looks like is a completely different matter. But I'd put refocusing on preventive health as a front runner by a long way.
And I guess, I mean, related to this, and possibly not huge amount of time for this, but there is a lot of talk about closing the gap. The situation where we find a significant health inequity in our First Nations populations. I mean, we talk about health reform, we talk about patient enrollment, we talk about telehealth, we talk about all these sorts of things, but I'm wondering whether a lot of these sorts of things will actually address the issue around closing the gap in any meaningful sense. Do we have hope that it will? And things like even Medicare rebates and all that sort of stuff, it may not mean very much to a group that don't seem to be able to access some of the services that we sometimes take for granted.
I might kick off just with a comment on telehealth. So there is the opportunity for telehealth to improve access to quality advice in remote areas. So for both First Nations people and others living in remote communities. So having access to, say, specialists or niche type advice and care, telehealth provides that in a way that would not be otherwise achievable. And especially when video is able to be used as well, it improves the quality of that interaction over just phone. So I think that's one way. It's a small way though. So it doesn't answer your question, Marcus, but from my scope of expertise, I guess, I think telehealth really can improve that. Another challenge though, so at Healthdirect, on our phone line, between 8 and 10% of our callers identify as Aboriginal Torres Strait Islander, which is over the proportion of that population in Australia. So we've made some good inroads in in creating trust in those communities to use Healthdirect's services. So that's something we're proud of and we want to do more of. But language is still a real challenge for us. There are so many Aboriginal languages, and we don't service them well. We use the TIS, which is a sort of a manual translation service that the Commonwealth provides, but they don't offer Aboriginal languages. So I think that's, for us, it's actually around language is our biggest challenge.
Oh, that's really interesting. And so just any final comments or addressing any particular sort of issues that maybe we talked about brief, just to wrap up, Stephen, just to start and end with the patient in mind.
Yes, look, just on Indigenous health, we're meeting a lot of Indigenous health leaders. They've got their own issues about fair treatment and, better discharge notes, but with a lot of them living in rural and remote areas, we know there's lack of bulk billing in those areas. There's a big shortage of doctors. So telehealth really is one of the solutions for Indigenous people, but there's multiple challenges and probably no easy answer, but at least it's on the agenda for a lot of parties. Look, from a patient perspective, the key issue now is cost of living issues. Too many Australians can't afford to see a GP. That is the number one issue. And the solution is more affordability and probably more bulk billing. And the government has made a start, but as Nick said, it's a start. It's too early to see how effective it will be. Hopefully it's very effective, and there's more initiatives in that area.
Thanks, Stephen. Look, I think we've come to time. So just in wrapping up, and we've had a very large, broad-reaching discussion, which I think has been fantastic. So thank you to our panelists today, Nick, Bettina, and Stephen. And also thank you for those of you who actually contributed in the Q&A. I think that was some fantastic questions there, and some interesting rapport back and forth between some of our colleagues as well. So for more on the Australian Healthcare Index, please visit australianhealthcareindex.com.au, download the report, and get access to the interactive dashboard. As I said, it is much more granular. You can actually filter it down to state level type of findings as well as demographic type of findings. So some really interesting stuff in there. And hopefully we will see you next time. So thank you again.